Welcome, everybody, to this module called the Snapshot of Risk Adjustment Coding. And this is going to be a snapshot of risk adjustment and HCC coding. And the reason we're going to do this is so that we stress why what we do is so important, okay? And so we have a long way to go in the program, but this is all to make you understand what you're doing, why you're doing it, the impact of what you do, and how important that impact is. Okay, so we're going to give you, just like watching a magician do a magic trick, okay, you are not going to get it the first time. Okay, but if you see the trick, then you want to figure out how the trick is done, right? So it is a good point here to take you through what it is that we do, and that way, as we move forward, it is going to make much more sense as to learning the why. Okay, so in the last module, we dissected a risk score. Okay, the four components: demographics, condition categories, disease interactions, and count of payment conditions. So let's go ahead and look at demographics and why it is so important for us to understand and what a risk adjustment coder, what role a risk adjustment coder will play in demographics. Okay, so we have this record here, okay? And what a risk adjustment coder is, the risk adjustment coder is the link between the documentation and the calculation of the risk score, okay? The risk adjustment coder is the eyes on the record. And aside from just assigning codes, which we are not just assigning codes, and I'll talk about that in a moment, we are checking for other things, okay? We need to check patient identifiers. We need to make sure that as we're going through a record, records aren't mixed, and this does happen. And so you have to be vigilant, and you have to be the lifeguard, if you will, okay? The data service, you have to make sure the data service for the reporting period that you're looking at, that you're tasked with, you got to make sure that the record falls within the data service, okay? And when we get to the module where we talk about what's called RADV, Risk Adjustment Data Validation Audits, if you understand this, it'll be much more clear as to the impact, okay? But so here is just a record, and so here we have Barney Rubble, 59 years old. We do not have a medical record number. We don't have a date of birth. Look, if that is John Smith, there could be a million John Smiths. How do we know we're working with the right John Smith? We need to have corroborating, information, a date of birth, a medical record number, unique identifiers. We need to verify that we are working with the right patient, okay? And it is not uncommon. It's not unheard of. I wouldn't say it's common, but it doesn't matter whether it's one time, 10 times, 1,000 times. When you get to a record, if Robert Smith is mixed with Barney Rubble, you need to isolate that record and have it sent back to your organization and or the health plan to have that record straightened out so that you are coding the appropriate patient. And again, data service, you must make sure the data service is within the data collection period. Okay. So that is the importance of a risk adjustment coder in the demographics area. This is the main, the highest function of a risk adjustment coder, and that's the condition categories. Okay, so let's take a look. So in the last module, when we broke down a risk score, I used the term mapping, okay? And so now we are going to get a lesson in what mapping is, okay? So we have this record here. This is John Doe, medical record number, age, sex, okay? We don't have a date of birth, but we do have the medical record number. Another patient identifier might be the unique health plan ID number, okay? But we have patient identifiers here, okay? And so the patient is here for follow-up for diabetes, chronic kidney disease, hypertension, migraines, and history of amputated left hand, okay? And so history of present illness, Mr. Doe, 55-year-old male with history of diabetes, chronic kidney disease, hypertension, migraines, and history of amputated left hand, is currently taking metformin, lisinopril, hydrochlorothiazide, and sumatriptan for his conditions. He presents today for a follow-up appointment, reports that his diabetes is well controlled, that his blood sugar levels have been within target range. He also reports that his blood pressure is well controlled and that his kidney function has remained stable. He denies any new episodes of migraines, okay? So remember, we talked about this thing called MEET, monitor, evaluate, assess, dress, or treat, right? And so that is all done here, okay? Right there in the HPI, it's done. If it wasn't done there, we're gonna look here a little bit further. We're gonna have labs, okay? We're gonna have medications. We're gonna have instructions, okay? So simply seeing a term such as hypertension, such as diabetes, is simply not enough to be clinically supported in the record. We need documentation of that thing called MEET. It must be monitored. It must be evaluated. It must be addressed. It must be treated. You only need one, but you need something to clinically support a term or a diagnosis that you see, okay? And so this is a decent record in that regard. So now that we've been through this record, let's talk about mapping, okay? And so let's look at the first condition, diabetes, okay? And so we have, if we code that properly, we have E1122, type 2 diabetes with diabetic chronic kidney disease, okay? Now, you're going to see, I have here, and I'm using two different documents, and again, we'll be going through this in later modules to explain more about this, because we are right now in 2023, we are in transition. You will see right to the right of where it says mapping there, you can see two columns. One is 2020 CMS HCC model category V24, and then you'll see 2024 proposed CMS HCC model category V28, okay? The V is version, okay? And so V24 is going away and V28 is being implemented. And in the transition, we're going through what's called a blended model. We'll discuss that more in a later module, but at this point, both versions are in effect, okay? So E1122 mapped to HCC 18 in V24. In V28, it's going to map to HCC 37. Okay, so mappings are a document. Okay, and actually, let me show you a mapping document. So this is an Excel spreadsheet from CMS that has a list of every single diagnosis code and its description that maps to an HCC. Okay, so this is from A to Z, okay? And so if a diagnosis code is on this spreadsheet, then you would look at the appropriate column. Does it map in V22? Does it map in V24? Okay, V22, V24. And then we have what's called RX HCCs, which we're going to cover in a separate module. We'll talk about it in a moment for just a few seconds. But this is the mapping. Okay, this is your secret decoder ring. Okay, when you see a diagnosis, you map. Now you may be working in a system that kind of does the looking up for you. So in other words, you might type a diagnosis into an input field, and it might come up yes or no, or what have you. But the data all comes from these official mappings from CMS. And so again, we have V24. Okay, V24 is going away. Now I'm using this again. You see V22. This was a previous model, and so there's been different models over the 20 years of HCC Medicare HCC risk adjustment. V22 has gone away. V24 is now going away, and we're moving to V28. Okay, and so there's another. Let me see here. This is another mapping spreadsheet that has side by side V24, V28. Okay, and just real quickly, you'll see here this diagnosis code qualified for an HCC in V24. It will no longer qualify for an HCC in V28. We'll talk more about that, but just to give you the to give you the foundation here, mapping is identifying a diagnosis code and whether it qualifies for an HCC. Okay. Now, the mapping spreadsheet does not tell you the value of that HCC. Okay. So if we're looking at diabetes here, and this is diabetes with diabetic chronic kidney disease, which maps to HCC 37. Okay. So we have to go to a separate document, and that is found in each year's annual announcement. Okay. And that's in your essential resources for risk adjustment coding. Okay. And so on that document, it would tell you HCC 37, diabetes and chronic complications, and it will tell you the weight. Okay. It'll tell you the weight for, and I didn't copy the headings here on the next slide. I think on a subsequent slide, we'll see the actual headings here. So HCC 37, and these are the mathematical weights. So remember, we're looking now at the HCC condition categories, right? And in the risk score, all qualifying HCCs will be added into that box, right? So let's go back and take a look. Okay, so the condition categories. Okay, so we have found a diagnosis that will go in there. And this is the weight that will go into the formula. Okay, so let's move on. Okay, and so now we have chronic kidney disease. All right, now in this record, it did not indicate the stage of chronic kidney disease. Okay, so this will be a coding challenge. Okay, we will not be able to code this. Well, we could code it. It'll have a code. It'll be chronic kidney disease unspecified. Okay, but we don't know if it's chronic kidney disease stage 1, 2, 3, 4, or 5. And since we don't know if it's 3, 4, or 5, which will map to an HCC, we will see you won't find chronic kidney disease unspecified in the mappings. So because the provider didn't document the stage, okay, we're not going to be able to pick up, it's not going to qualify for an HCC, okay? And so as a risk adjustment coder, sometimes you will have the opportunity to query a physician, depending on your environment. Now, in most cases, the risk adjustment coder does not have the opportunity to query a physician, but in some cases they do, and we'll talk about that in a subsequent module. But in this case, we have chronic kidney disease. We do not have the stage, so we cannot assign a code for a qualifying stage. We'd have to assign the code for chronic kidney disease unspecified, and that would not map to an HCC. Let us, for example's sake, say, okay, it was documented as chronic kidney disease stage 3. Okay, so then we would need to know if it's 3 unspecified, 3A, or 3B, okay? Because 3B is HCC 328, and 3A or 3 unspecified is HCC 329. What difference does that make? Okay, well, down here, you will see now in this particular case, the weights are the same for 328 and 329, but that is information you will not typically have right at your disposal, and you shouldn't be looking at that anyway. You need to be coding and let the HCC's values take care of themselves. But in this particular case, 328 and 329 would be the same weight. Why do they have 2 different HCCs for it then? Well, because it was just statistically, mathematically, it came out that way. When they rerun the formula next year, it could be a different weight. Okay, so they could be different weights. So we have the mapping here. We have found chronic kidney disease, and we're assuming right now that it says chronic kidney disease stage 3. Okay, and because it didn't specify A or B, it would be chronic kidney disease stage 3 unspecified, and that would map to HCC 329. Okay. And so for HCC 329, as I mentioned on the previous slide, I hadn't copied the headers here. Okay, so here's the variable, what HCC it is. Here's the description. And then remember demographics, okay? The weight will change based on the demographics. So community, non-dual eligible, aged into Medicare, this would be the weight. If the patient is community, non-dual eligible, but was the original reason for entitlement was disability, then this would be the weight. Okay, and again, remember, risk adjustment coders do not have to sit and calculate the risk score. Okay, it is important for you to understand what you're doing, why, and the impact. Okay, and that's what we're explaining here. So again, mappings is up here. You found chronic kidney disease. You have assigned the appropriate, the highest level of specificity diagnosis code. We found that it mapped to an HCC, and then as the risk score, so as that is reported, and as the risk score is calculated, it will have a weight. Okay, so let's go on to hypertension. So hypertension. Let's take a look here. Okay, there are, and we're going to be going, as I mentioned, RX HCCs. You have 4 parts of Medicare: A, B, C, and D. Okay, Part C is where health plans take over the responsibility of claims payment for Part A and Part B, right? So, but Part D is prescription drug coverage. And Part C plans do not have to offer prescription drug coverage, okay? And if they do not, then the beneficiary can go out and get Part D coverage through an approved source. If the Medicare Advantage plan does offer prescription drug coverage, then the beneficiary cannot go get a separate Part D plan. And because the Part C plan is taking over responsibility for prescription drugs, they will get HCCs mapping to prescription drug conditions, okay? And again, we're going to go through RX HCCs in a separate module, but hypertension here, okay, is not, you'll see here, and this is, I'm using the V24 mappings here. HCC, 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 you'll see that there's no hypertension does not qualify for an HCC. It does qualify for an RX HCC, RX prescription HCC, okay? And that is because hypertension is not something that is going to statistically and significantly increase the cost burden to the health plan from a treatment perspective, but it is going to increase it is maintained by drugs. Okay, hypertension, hyperlipidemia, osteoporosis. I know, you know, many conditions are treated specifically and only with medications, okay? And so they will often qualify only for an RX HCC. There are conditions that will qualify, and I don't know if I have it copied here. I do not, but in diabetes, it will often qualify for an HCC and an RX HCC, okay? When a condition is significant enough to qualify for an HCC, then it may qualify for the HCC, and it may carry a very significant, prescription drug burden as well. So we'll talk more about RX HCCs. But again, as a risk adjustment coder, you are capturing all conditions that map, okay? So hypertension maps. Now, you will be given instructions by your organization whether to capture RX HCCs or not. If you're capturing for a health plan that does not offer prescription drug coverage, there's no point in capturing the prescription drug diagnoses, right? So we'll talk more about that in another module, but that is a condition that we're going to pick up, okay? Next, we have migraines, okay? And again, same thing, all right? You see these 4 columns where it says HCC, 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 okay? These do not qualify for HCCs. However, they do qualify for RX HCC, okay? And so, again, you will be, you need to understand, why you are picking up conditions, why you are not picking up conditions, which conditions to pick up, okay? And it all comes from the mappings, okay? So I want to take a look at the amputation of the left hand, okay? And this is very important, okay? Because certain conditions may, you might see amputation, you might say, oh, that risk adjusts, okay? Well, not always. Okay. Amputation of an upper limb will only risk adjust. You see here, traumatic amputation, traumatic amputation, traumatic amputation. Okay. So the beneficiary is out using their wood splitter, their wood chipper, and they get their hand caught in there, and the hand has to be amputated. Okay. So in that year that occurs, that traumatic amputation occurs, the upper limb amputation, traumatic amputation, will risk adjust, okay? But except for very, very, very rare circumstances, or very unique circumstances, which we're going to look at on the next slide, in subsequent years, history of amputation will not risk adjust. And actually, that is going to be true actually for lower limb as well, except in certain circumstances. So amputation of left hand, as we're going through this record, we need to know, was this hand amputated 10 years ago, or did this happen in this data collection period? Okay, and that is where we need to, be assigning a code, based on the documentation and completely, accurately, and to the highest degree of specificity. Okay. So again, traumatic amputation means it happened. Okay. It happened in this record. Okay. Not 10 years ago. All right. And that's going to be very important. And you will see here again, we have V24, and I am bouncing back and forth between two mapping forms, and not to confuse you, but it was just to highlight certain pieces of information. So you will see that certain diagnoses will risk adjust in V24 and not in V28, and others will risk adjust in both. However, as I mentioned in a very earlier module, with the exception of the first 3 HCCs, all the HCCs are being renumbered. Okay. So if this was, the scenario I painted where the beneficiary was out working in their yard, they have a wood chipper, they got their hand caught in there, and they lost their hand. HCC 405, and there is our weights. Up here is the mapping. Up here is the risk adjustment factor. Again, 2 different documents. The mapping is a spreadsheet provided by CMS, available from CMS, that tells you simply whether a diagnosis code risk adjusts and to which HCC. That's the mappings. Okay. And then in a separate document, always in the annual announcement, there's a list of the HCCs and what their relative value is. Okay, so let's move on. And so let's talk about these things called hierarchies, right? HCC, hierarchical condition categories. Okay. And again, we're going to do a separate module on this, but this module will be incomplete if we didn't touch on it. Okay. So remember we had, I'm going to work from the bottom here. Okay. Amputations and complications. There are two HCCs, 405 and 409. Okay. And so I don't think so 405 would be that traumatic amputation. 409 would be basically a complication after the fact. Okay. So so if we have in the same patient, if we have HCC 409 and 405, if we have 405, we do not count 409. Okay, let's look at our chronic kidney disease. Okay, remember chronic kidney disease? If we have HCC 328, 329 will not count. If we have HCC 327, 328 and 329 will not count. And if we have HCC 326, 327, 328, 329 won't count. That's called trumping. Okay, same thing in diabetes. If there's only one code in the pancreas transplant status HCC, and that is pancreas transplant status. But if the patient has had a pancreas transplant, all other diabetes HCCs will not count. Okay. If the patient has not had a pancreas transplant, then if they're a diabetic with severe acute complications, that will trump diabetes with chronic complications or with diabetes without complications. If in the case of the diabetes with chronic complications, chronic kidney disease, of course, that will trump HCC 38, which is diabetes without complications. Okay, so this is when we talk about HCCs, this is the hierarchies. Okay, so within a condition category, so here we have 3 condition categories here. We have diabetes, we have chronic kidney disease, and we have transplant status. Okay, so and each of these has a hierarchy. 405 and 409, the highest is going to count. In the chronic kidney disease, the 326, 327, 328, 329, okay? The highest one will count. And in the diabetes hierarchy, the highest one will count. So we'll have 1, 2, 3 values, okay? Those weights, those relative values, 3 different ones will go into that box for condition categories, okay? So it is important under condition categories to code completely, to code accurately, to code to the highest level of specificity, and to make sure that every diagnosis has clinical support using that term meet, okay? Because if you are not coding completely, and we discussed disease interactions, and that is when 2 conditions that each equal an HCC are together, then there's an additional factor. So if we miss a condition that would be worthy of a disease interaction, then this third box is going to be inaccurate, okay? And if we are missing conditions that would qualify for an HCC, that will create a scenario where our condition count will be off, and that box can be affected. Okay, so this is a demonstration of, the importance of what you're doing. We kind of went through, and I want to take you over, and I want to look at 2 records, and we're gonna be doing this a couple times throughout this program, so that you are fully aware of what you are doing and why. But I want to take a look at 2 records here. Okay, first, let me unpause my screen. First, we have, and this is where this is to illustrate why you have to be diligent and mindful and vigilant, okay, as you're coding, okay? So we have this patient who had a visit on May 1st, 2017, okay? And I happen to know that this is their first visit with this provider, okay? And first of all, and this would not likely impact risk adjustment, but from a clinical documentation perspective, you should be aware of these things. And if you are a coder, say in a medical office, you should be calling this to the attention of the provider. Allergies, no known drug allergies, and then it lists penicillin and Zithromax. Okay, so that is a documentation error. Okay, that is a clinical documentation error. Okay, but it gets worse. So on May 1st, the patient was 4'10", 97 pounds. Okay, and their BMI was 20.32. Okay, remember that. 4'10", 97, 20.32 BMI on May 1st. Okay, they came back to see the provider on May 3rd. Okay, May 3rd, 2 days later, and the patient is now 4'10", 198 pounds. They gained 101 pounds in 2 days, and their BMI is now 40.76. Okay. I would like to say that somebody hit the just hit the 1 on the 10 key, but that wouldn't explain the 8 versus the 7. But anyway, 2 days later, this patient went from 4'10", 97 pounds to 4'10", 198 pounds. That's bad, right? Oh, well, folks, it gets worse. May 9th, okay? This is 8 days, in a period of 8 days, okay? Patient comes back, and now on the problem list, active problem, morbid obesity. This patient in 8 days went from 4'10", 97 pounds to 4'10", 198 pounds, and is now, their record is reflecting morbid obesity. Okay. And this is absolutely a documentation catastrophe. Okay. So I show you this to reinforce that as you go through records, you have to play detective a little bit, but more so this is why you must have clinical support. You can't just see morbid obesity and code morbid obesity. Okay. And in the next record we'll illustrate this again in another uh perspective as to why you just can't do that. That's not coding. If you were just transcribing words into, then you wouldn't need a certification. Okay. You need to make sure that the documentation is complete and accurate. You have to look for uh, uh, discrepancies and blatant errors. Okay. Now, this physician should not be signing this record. Okay. And clearly this physician did not review this record, the way they should. And that's a documentation error. So that is one, and you will see these records again. You'll see these two records and more as we go through the program. But again, this is a snapshot. This is to get you understanding what you're doing, why you're doing it, the importance of what you're doing. Okay. Let's look at another one. Okay. And so I'm gonna pump this up a little bit. Oh, 200. HPI, patient is here for test results, reviewed and discussed with her. Vitamin D, WNL, if you don't know what that means within normal limits, but in the lower limits of normality. Okay. So basically what this sentence says is their vitamin D is normal. I don't care whether it's in the lower limit of normality. I don't care if it's directly in the center of normality. It's normal. Okay. And there is no diagnosis code for normal conditions. If there were, the diagnosis book would fill a tractor trailer. Okay. So again, this is patient is here for just to review test results. We reviewed the test results with her. Her vitamin D is normal. Patient's feeling good. Just notes that there's a cervical x-ray due on, blank and blank. Okay. Medical history. We have cancer of right breast. Okay. But that's medical history. No known drug allergies. Which did we have that? No. Okay. That's the other one was, we have the vital signs, and we have physical exam, NA. There was no physical exam performed. Okay. Patient came in to review the lab results. They reviewed with her. There was no exam done. And now we have today's assessment. Count them, folks. There's 19 diagnosis codes there. Some of them risk adjust, some of them don't, but none of them, the only one that could possibly be accurately coded would be the history of malignancy of the breast. Okay. Now I do know that I understand these are also ICD-9 codes. Doesn't matter really. Documentation is documentation. The code assigned based on the documentation is obviously ICD-10 now, but and again, this is to illustrate that there is no meat for unspecified inflammatory polyneuropathy. There is no meat. It was not monitored, evaluated, addressed, or treated for unspecified inflammatory spondylopathy. There was no meat for senile osteoporosis. There was no meat for degeneration of cervical disc. Okay. There was no meat for stricture of artery, no meat for atherosclerosis of the aorta. There was no meat for spinal stenosis in the cervical region, cervicalgia. And now cervicalgia, okay, the patient, let's see, we have 1, 2, we have 2 diagnoses where cervicalgia is neck pain. Okay. Well, that would be a integral part of spinal stenosis and degeneration of the cervical disc. So that would be incorrect anyway. Okay. And so you must, the point here is you must understand documentation guidelines, and this comes straight from, among other places, but your first and foremost is your ICD-10 official guidelines of coding and reporting. Okay. And then medical CMS medical record requirements that all diagnoses be supported. Okay. But there's 19 diagnosis codes here, and absolutely none of them are addressed in this record. Okay, not mentioned in this record, not supported by any corresponding diagnostics or treatment or anything. Okay, and here we have a problem. Okay, is many coders will just transcribe these codes or these conditions. Okay, that is absolutely non-compliant. That's not why you are a certified coder. Otherwise, you would be a certified data transcriber. Okay, and so you must make sure that records reflect and support any diagnoses. Okay, I have had people say, "Well, I can't change a diagnosis." You are not changing a diagnosis. Okay, and we'll talk about more about this in later modules. There's a thing called Coding Clinic, and we're going to do a module on Coding Clinic. And it is not sufficient for a provider to pick a description off a pick list and use that as a diagnostic statement. Okay, this is why you must have clinical support in the record. Okay, and if there's not clinical support, or if the what if the provider document a patient has chronic kidney disease stage 2, and then at the bottom assigns the code for end stage renal disease, you would certainly have the authority and the latitude as a certified medical coder to correct that diagnosis code to reflect what the record indicates. Okay, so many people have misconceptions about that. You've spent a lot of time, a lot of money, a lot of effort to become a certified coder. Do what a certified coder does, and physicians, providers are not medical coders. They're trying to get through a record as quick as they can. They pick a thing off a pick list, and that is how errors happen. One of the many ways that errors happen. So again, this record. So we have two records that we've looked at. You're going to see these again. But that we had a patient who went from 4'10", 97 pounds to 4'10", 198 pounds in 9 days. And folks, if this person was going to apply for a life insurance policy, they could be denied, a life insurance policy because of that. A pilot, imagine a pilot who is diagnosed with epilepsy errantly, or some heart or condition. They could be grounded while that's all sorted out, and that could take weeks, months, years. Okay, so all from inaccurate documentation. So morbid obesity. Here we have basically the provider said, the reason today's visit is normal vitamin D, and then we got 19 absolutely unsupported diagnosis codes. So again, this to illustrate in a snapshot the importance of what you're doing as a risk adjustment coder. Okay, and so let us go back to the presentation, and let us just remind you that these are the 4 parts of a risk score as we discussed in the last module. Okay, and this is the importance of what a risk adjustment coder is doing when they are coding these records. Okay, so this is this is the snapshot. This is the underlying why. Okay, and in subsequent modules, we're gonna dive deeper into the why and how. And this is Medicare HCC, Medicare risk adjustment. Remember, there are risk adjustment models for commercial under the Affordable Care Act and for Medicaid. And in subsequent modules, we will talk about the unique, differences of risk adjustment in those realms. So that is today's presentation. Again, snapshot of risk adjustment coding. And hopefully that will, as we move forward, it's a lot easier to comprehend some of the things that we're going to be going through, if you have at least a basic understanding of why. Okay. And we're going to dig deeper into the why, and we're going to dig deeper into the how and the theory behind it. So we will see you in the next module. Thanks, everybody.